Okay, we'll be covering the respiratory system today. And the anatomy and physiology of the respiratory system, make sure that you review it and understand the different anatomical structures within it. So what it does is it distributes air and gas exchange within the circulatory system. So there's the upper and lower respiratory system. And here is some of the pictures for you. You can see the pharynx, brachii, the lungs, the tracheus. You see the carina. The carina is a huge point for us. When we run angios, we're usually placing our ROIs at the carina, so it's really important. It's at the level of T5. So in the thoracic cavity, you have pleural cavities. You have a parietal pleura and visceral pleura. Within the mediastinum, there's anterior, middle, and posterior. In the anterior, you have your thyroid and thalamus glands. In the middle is your heart, great vessels, esophagus, trachea, and the posterior is your descending aorta and your spine. Make sure you know the anatomy in the different areas within the mediastinum. Okay, in your bony thorax, you have your ribs, your sternum, and your thoracic vertebral bodies, or your spine, and you have your paranasal. There's paranasal sinuses. You have the maxillary, ethmoid, and those are present at birth. So when we look at imaging considerations with radiography, the exposure factors, it's pretty tough to know exactly what's going on inside the chest. So we use digital imaging, and we use automatic exposure control, which is AEC, as it provides a more consistent image density for us. So the projections of the chest, we do PA and lateral, and we usually have a 72-inch SID to reduce the magnification of the heart. We want the patient upright as much as possible so we can see if there's any air fluid levels, and also to decrease the engorgement of the great vessels. So looking here at a chest x-ray, we've got the left side. Here is your left side of the heart, and your apices are up top, and your costophrenic angles, and you have your cardiophrenic angles, and you have your hilum in through here. So those are just the basics. And if we look here, here is your cardiophrenic and your costophrenic angles with your hilum right here, and here's your heart. So the big thing is on the heart, make sure you outline the heart. It's here. Up here is your aortic knob and your aortic notch. So there's a notch and a knob. And the heart does not go all the way up here. The heart comes around here. Okay, so this is your right side of your heart and your left side of the heart. There's soft tissues of the chest, and they vary with depending on patient's age, sex, and pathological conditions. So there's the pectoralis muscles. There's breast shadows that you may see. There's breast prosthetics that you may see, and sometimes the nipples are dense and they will show up and they look like a lesion on a chest x-ray. So bony structures of the chest, the ribs, so there can be abnormalities of the ribs, and you can get calcifications of your cartilage, your costal cartilage, and there can be fractures. So one pathology of the sternum is the pectus excavatum, it's hard to say fast, where it's depressed in. So on your thoracic spine, you can have scoliosis, which is curvature, kyphosis, which is hunchback, and compression fractures. Your mediastinum, we talked about what's in the anterior, middle, and posterior, and you can get what's called mediastinal emphysema or pneumomediastinum, where air is trapped and it displaces the esophagus. So you'll see air within the mediastinum. That is not a good thing. A lot of it is because of ulceration, so from reflux or cancer. Well, you'll perforate your esophagus and air will go into the mediastinum. There's subcutaneous emphysema where there's free air within the soft tissues, and that can be from an air mediastinum. It also can be from a punctured lung. You'll get air within the in the soft tissues. Also, when patients have surgery, the air can go in the soft tissues all over the body. Okay, we have the thyroid gland. It's located superior to the lung apices, and it may displace the trachea. So you see some weird abnormality within that area. It could be the thyroid. So as you can see here, enlargement of the thyroid gland. You see the trachea is right here, and it should be midline. So you can see that it's just placed off to the left. So there's an enlargement of the thyroid gland. Looking here, this is your air in your soft tissues, peritoneum right there. So all this is free air. So this person had a punctured lung, and the air from the lung was leaking into the soft tissues. Very painful, very painful. All right, for the chest, typically we do computed tomography. We can do volumetric CT, high resolution CT. We can do needle aspirations, biopsies, and it's a modality of choice for pulmonary adenopathy. There's pulmonary embolus, small cell, carcinoma, and METs. Looking here, this is a PET scan, and we do PET scans for perfusion as one reason to see if there's any filling defects. So there's ventilation scans and PET. We have FDG, where we're looking at nodules, and we have SPEC CT. So it's PE and chronic obstructive pulmonary disease is what it's really good for. So as you can see here, the right lung is fully intact and the left lung looks good. You have this shadow right here. That's the heart. That's normal. If we look here, this is pulmonary embolism, which is a blood clot from the lower extremity, usually popliteal, that comes up and goes through the heart and places itself within the lung. So it's a blood clot. And you can see there's no filling here. So this is normal. You can see there's no filling. There's filling defects off to the side. So you can see on the right, you've got the whole middle wiped out. The whole top APC is gone, and your lateral there on your left. Okay. Tubes, lines, and catheters, imaging consideration, patient's conditions when positioning and covering the cassette to prevent disease infection spread. So the different tubes that we're going to talk about is the endotracheal chest tube, central venous pressure, so CVP lines, pulmonary artery catheters, so usually we call them a Swan-Ganz. So the intra-aortic balloon pump, so ABP. The access catheters, so there's a Hickman or a portacath, and the difference between a Hickman and a portacath, the portacath is usually under the skin, where a Hickman comes out of the skin. It has a dual port, and it's kind of IV lines kind of hanging out of the skin. And you have your ventricular pacing electrodes. So here's your different tubes and where they should be placed and what happens if they're not placed right. So your ET tube, the tip of the tube should be 5 to 7 centimeters above the carina. So low placement will cause atelectasis. High placement, air entering into the stomach, and that's not good. Central venous pressure catheters. So the tip of the catheter should be in the superior vena cava. So complications from that is your internal jugular vein placement. It's supposed to be placed in there, sorry. It needs to be by your right atrium, and if it isn't, it should be superior to the right atrium. So if it is in the right atrium, it can cause arrhythmias or perforation. It can cause a pneumothorax and infusion of fluids into the mediastinum, which is not good. So Swan-Ganz catheters, it should be in the right or left pulmonary artery, and if you put it in the wrong spot, it can be pulmonary infarction. So transvenous cardiac pacemakers. So you want to make sure that you can see the lines going in, and if it's not placed properly, you can perforate the heart. Just not good. So looking here, this is correct right there. Your ET tube should be right there, and this one comes all the way down, and it's looks like in the right main stem bronchus, which is not good. So your left lung is not getting aerated properly. So this is where it's placed properly. And then you have a central line coming in here. And that actually looks like a Swan-Ganz. It's going up pretty high. All right. So looking here, this is a chest tube right here. And this is a PICC line coming in, and it's seated right above the right atrium. So the right atrium is right in here. So it's seated right above it. Perfect. All right, so this is an IABP, so it's an intra-aortic balloon pump. And kind of hard to see because this image isn't penetrated well, but we've got a balloon pump in here, so it's hard to see. So I'd give you an image that looks better. I probably wouldn't give you an image on this because they're not common. All right, so pacemakers, as we know, the lines are coming down and around, and it's hard to see on this one. You can see it because it has little metal markers, which is really nice. Not all of them have these markers. And if you invert the image, you can see it placed proper. All right. Respiratory failure. What are we dealing with here? It is a lack of respiration function. So it's a lack of oxygen and carbon dioxide exchange. It may occur following acute trauma to the chest or a result of acute or chronic lung disease. So there's interpulmonary gas exchange, that's within the lungs, and you can have impaired breathing, so the inability to move air into and out of the lungs. So with hypoxemia, low oxygen levels within the arterial blood, and results from failure of gas exchange. Common causes is toxic gas or smoke inhalation, high altitudes, hypoventilation, chronic obstructive pulmonary disease, so COPD, atelectasis, and severe pneumonia can cause this. So congestive heart failure, it may also caused by shunting of blood from the right side of the heart without passing through the lungs. So the blood is bypassed and it doesn't go to the lungs. So that can clearly cause some problems. Hypercapnia, so failure of ventilation from the inability to move air into and out of the lungs caused by increased carbon dioxide content, causes upper airway obstruction. Insufficient respiratory drive, respiratory fatigue, or paralysis and dysfunction of the central nervous system. That doesn't sound good. Symptoms are irregular or gasping breathing pattern and a rapid heart rate. So the way that we diagnose it typically is ABG, arterial blood gas, primary method for measuring and diagnosing respiratory failure and determining the severity of the failure. So there's your values. So looking here, establishing a new airway for these patients, we use bronchodilators, we use controlled oxygen therapy, and non-ventilator masks. So we use continuous positive airway pressure with the CPAP and bilevel positive airway pressure, BIPAP devices. Some individuals may be placed on a mechanical ventilator. Okay, going into our congenital and hereditary diseases, we have cystic fibrosis is our first one. It's a autosomal recessive gene affecting the exocrine system. So it affects the lungs, the pancreas, sweat glands. It's progressive mucus clogging the bronchioles and bronchi. So you have this chronic cough that's non-productive. You have frequent pulmonary infections, and it can lead to respiratory failure. So that's a bummer. So most lethal genetic disease for white children, early diagnosis is key. We take radiographs taken over a period of the duration. The prognosis is usually death by 40, within the 40s. I had a student that had this, and he was 32 when he passed. Very sad. So treatments is we use antimicrobial drugs, inhalers, respiratory physical therapy, lung transplant at end-stage disease. My student was on IV drug therapy to help with the surfactant and clearing out and making his lungs more productive. All right, so signs and symptoms. So chronic cough and wheezing with recurrent chronic pulmonary infections. You get barrel chest from the constant trying to breathe. You have clubbing of the fingers and discoloration of the skin as the disease progresses. All right, hyaline membrane disease, RDS, respiratory distress syndrome. It happens with premature infants. It's incomplete mature of the velar cells and causes unstable alveoli. And it's a deficiency of the surfactant. So the surfactant is like the lubricant, and it causes widespread atelectasis. So the signs are rapid and labored breathing in the first 24 hours after delivery. And the appearance radiographically is severe atelectasis with air bronchiogram signs. characterized by bronchioles surrounded by non-aerated alveoli. So the treatment is regular monitoring and maintenance and proper oxygen levels. It usually resolves within 4 to 5 days. So looking here, this is what it looks like. They call this ground glass appearance. So you can just see all over diffuse spotting. Ground glass appearance is what we call it. All right, so pneumonias. Most frequent type of lung infection is the 8th leading cause of death in the United States, and the most common lethal nosocomial infection. It can be bacterial, virus, and mycoplasmas, and infection effect. So there's lobular, segmental, bronchial pneumonia, and interstitial. The symptoms of cough, fever, sputum production that develops over days, and radiographically we see alveolar infiltrations of pulmonary densities. So there's lobular pneumonia, it's most common, bacterial pneumonia, and it's generally precedes by upper respiratory infection. There's Staphylococcus pneumonia, and it's thin-walled air-containing cysts that you'll see within the images. So if we look at the Staphylococcus pneumonia, it's sporadically, except for influenza outbreaks, it's severe and it can be fatal. Pneumatocysts, you'll see, and there's characteristics of lesions and typically seen in children. So it's patchy areas around the bronchi is what we see. We use drug therapy with a chemotherapy agent, which is crazy, huh? All right, this is what it looks like. So you can see we have a piece of atelectasis here. This just looks really bad. There's all kinds of problems with this image. All right, Legionnaire's disease. So Legionella pneumophilia, so transmitted through warm, moist places, heating and cooling systems like heating air conditioning units. Symptoms is malaise, muscle ache, chest pain without productive cough. There's vomiting, diarrhea. You're just a mess. So we'll see on images patchy infiltrates throughout the lungs, and we treat it with antibiotics and oxygen. And this is what it looks like. So you can see all this white in here is not good. All right. Mycoplasma pneumonia is caused by mycoplasmas. It's the smallest group of living organisms. Characteristics of both bacteria and viruses, but classified as bacteria-like. So it's usually older children and young adults, and it appears as fine reticular pattern in a segmental distribution. There's patchy areas of consolidation, and sometimes it looks like TB. So that's kind of scary. But if it's in the apices, it does. So you can see here, this whole area, you see how it's kind of patchy in its appearance. So that's what it looks like. All right, aspiration pneumonia. So it's a chemical pneumonia. It's caused by usually the lower respiratory tract where you have reflux or vomit, and it gets into the lungs. So you see edema produced by irritation of the air passageways. The way to correct it, you work on correcting the hypoxia, and then you control the secretions, and you need to replace fluids, and we use the antimicrobial drugs to help. All right, so this is what it looks like here. So you can see not good, lower respiratory. All right, viral interstitial pneumonia, most common caused by influenza virus A and B, more common than bacteria but less severe. So it's more common but less severe. Diagnosis based on clinical findings and serology tests. We don't do a lot of radiography for this. So you usually have a dry cough and a fever, so we just relieve the symptoms, and as it doesn't respond to any antibiotic treatments. All right, and this is what your viral pneumonia looks like. So just markings throughout. You don't have nice black lungs. All right, so you can see you have upper lobe here, right upper lobe. That's not good. Legionnaires, you can see another picture of Legionnaires. All right, so bronchiectasis. We're into our inflammatory diseases. It's an abnormal dilatation of one or more of the bronchi, and the symptom is chronic cough, or it's asymptomatic. Radiographic appearance is increased bronchiovascular markings, outline dilatation of the trees. So you'll see tram lines. So you'll be able to see the bronchial trees, and we call that tram lines. And CT is the best for this. So here you can see the outline, and that is what we're talking about. All right. And inflammation. Inflammatory diseases continue. We have pulmonary tuberculosis. So the cause is inhalation of mycobacterial TB, and it can affect the GU system, the CNS, or the skeletal systems. I've actually seen TB in the bones. It's really crazy. Rising occurrence, especially in the US, we typically do a skin test to diagnose, but I found that quantiferon is great. It's a blood test that we use, and I can actually see the values of the positive. So the skin test, you can have all kinds of weird reactions to it. So the signs are lesions in the apices of the chest, and the symptoms are morning cough with mucus, minimal mucus. As the disease progresses, the coughs become more productive. Patients complain of shortness of breath, and there's spontaneous pneumothorax or pleural effusions may develop, and night sweats are another one that they don't have listed, but night sweats are common also. So, looking at pulmonary tuberculosis, so we have fibrocaseous TB. Usually if a patient shows active signs of TB, there's cavitations that go within the apices. There's miliary TB. Oh, that's miliary, not military. Oh my gosh, this PowerPoint. So I apologize. This miliary resembles, reblanches to millet seeds. So I'll show you what that looks like on an x-ray. I actually have a picture of it. So there's small and white grains. The prognosis is death if you don't treat it. So there's two different ways, two different drugs that you can use to put it into remission. And if it's extreme, we will resect the lung to take it out. So you can see cavitation. So there's a big round circle right here, and that is typical in the apices of the chest of TB. We'll see those cavitations. This is miliary, so it's just like sand has been thrown in the lungs. This is what miliary looks like. It does respond to antibiotics and different drugs for TB. I've come across patients with this many, many times. And you can see up here, there's different cavities. This is the cavity one. So it's not miliary, it's not throughout the lungs, it's just in the apices. COPD. So we're looking at a group of disorders causing chronic airway obstruction. So chronic bronchitis and emphysema is the most common, and you have an increase of your mortality rate, and your risk factors go up if you smoke or you're around a lot of dust or chemicals. So chronic bronchitis causes long-term cigarette smoking or prolonged exposure to high levels of industrial air pollutants. So we see a lot of that. Symptoms: persistent cough and expulsion of mucus or phlegm, wheezing, shortness of breath, arterial hypoxia. So treatment: eliminate cigarette smoking. Pulmonary rehabilitation, antibiotics to reduce presence of infections. So lungs remain in chronically inflated state because more air is inhaled than exhaled. So it's hard to get the air out. And I'm sure you've seen all those commercials talking about that. So on chest x-rays, it shows hyperinflation of the lungs. Emphysema, the villi become distended from loss of elasticity. They become like scarred. So typically we see a patient with shortness of breath. The chest x-ray will show depressed or flattened diaphragm. So the diaphragm is going to be straight across instead of angled down at the costophrenic angle. It'll be flat. Abnormal radiolucent lungs, so they're going to be clear. There's going to be nothing in them but air. An increased retrosternal airspace, so barrel chesting, large bulla, predominant hilar markings, and blisters filled of air. So there's going to be like these round pockets of air. CT demonstrates small lesions, and bullae, the best. Bullae is like a pocket of air or infection. So treatment is the same for chronic obstructive bronchitis. So emphysema here, I don't see any bullae, but you can see the lungs, what we talk about when we say barrel-chested. So from here to here, it goes straight down. So this side is really extreme. So you can see normally the lungs come at an angle out to the costophrenic angles. So they're wedged, where this is straight down. So you can see it's pretty straight. We call that barrel-chested. Pneumococcal is occupational lung disease. Inhalation of foreign dust particles on a radiographic lesions will show such as nodules, cavitations, and pleural thickening. There's three primary types. There's silicosis, anthracosis, and asbestosis. So silicosis is the oldest form from inhaling silica dust. So miners, grinders, sandblasters. Anthracosis is black lung disease from inhaling coal dust and over an extended period of time, and asbestosis from inhaling asbestos dust. All right, so fungal diseases. So a fungi is a plant without chlorophyll and are widely found in nature. So there's histoplasmosis. It's a systemic fungal infection caused by histoplasma. It's in soil fueled by bird and bat extria. So diagnosis is made by histological lab, and the symptoms is nonspecific, include fever, cough, and malaise, and the treatment is usually less than 1% require it. And most forms of the disease are self-limiting and remain undiagnosed. So most of the people with histoplasmosis just think that they have the flu. Coccidiomycosis is caused by dymphoric fungus. So chest x-rays show small areas of pulmonary consolidation. Lesions may be varying in size, and nodules which require biopsy or surgical excision. The treatment is normally just bed rest. So if we look here, anthracosis, you see these here. You see all in here. Oh, not good. All right, lung abscess. So necrotic lung tissue surrounded by inflammatory debris causes periodontal disease, pneumonia, neoplasm, or other organisms that invade the lungs. It's more common in the right lung due to the vertical orientation of the right main stem bronchus, and you'll have fever, cough, you'll pus, and foul sputum. Radiographic appearance, lobular or segmental consolidation that becomes granular in shape, and pus accumulates. Empyemas is accumulation of pus in the chest, in the pleural cavity, causing lung infection, and usually we use antibiotic therapy. So we'll sometimes put drains in it and drain out the pus. That smells wonderful. Pleurisy, inflammation of the pleura, indicative of pneumonia or pulmonary embolism, TB, or malignant disease. Radiographic appearance only shows pleural fluid associated with the disease. Usually we use anti-inflammatory drugs, pain relievers, and rest. Patients with pleurisy are in a lot of pain. Pleural effusion, so it's an excessive fluid collection in the pleural cavity. So the fluid, as you can see here, this is fluid. You can see the fluid lines, air fluid line. So it's straight across, so we know that that's fluid that's in there. A hemothorax is pleural effusion containing blood from trauma, typically, or surgery. And we'll have blunting of the costophrenic angles on an erect or lateral chest, and it may displace the lung completely. So we're pretty close to displacing the lung completely. So the causes can be inflammation, exudates, it can be transudates, and the treatment is a thoracentesis, where we go in with the needle under ultrasound guidance and we hook them up to a vacutainer. We can place a chest tube, and we can give diuretics and antibiotics to clear up any kind of infections or to reduce the amount of fluid within a patient. So this is what it looks like on a lateral. This is a lateral decube. So you can see there's a line right there. It's displacing the lung. and from the ribs. So the lungs should go out to the outer ribs there. Sinusitis. So common causes of streptococcal, pneumococcal, influenza, staph. So usually follows acute viral infection of the respiratory tract. The ethmoid sinuses are most commonly affected because of its proximity to the nose. So the symptoms are nasal drainage, headache, tenderness over the affected area, toothache, and general malaise. CT is preferred modality because it demonstrates swollen mucosa, membranes, and retained exudate caused by infection. So an upright sinus x-ray may show increased density, but it's harder to see. The treatment is saline sprays to help clean it all out, antibiotic therapy, and pain relief, because it's sinusitis is not fun. So this is a CT. We're looking here, you can see the maxillary sinuses has debris within them, and here's your ethmoid sinuses with debris. And this is axial, this is coronal, and you can see the ethmoid sinuses here are full of snot, and then you can see here in the maxillary sinuses the layering of the fluid within the sinuses. All right, so let's go into your neoplastic diseases, and we have bronchial carcinoid, which is adenomas, usually considered benign, but included in the World Health Organization classification of lung cancer. So they invade local tissues, sometimes metastasize to regional lymph nodes, and are treated like malignant neoplasms. They're rare, 1% of lung tumors, and they occur equally between men and women. So the radiographic appearance shows opacity, bronchial narrowing, obstruction, or both. The bronchial obstruction is the most common, and recurrent pneumonia within the same area of the lung. So a lot of times we'll clear up a pneumonia and then we'll see this underline. So bronchiogenic carcinoma is the most common fatal primary malignancy in the United States. Oh my gosh. So there's 4 main types: squamous cell, adenocarcinoma, undifferentiated large cell, and undifferentiated small cell. Radiographically, usually shows airway obstruction caused by unilateral hilar mass. Lesions must be greater than 6 millimeters. So a coin lesion is a solitary radiopaque lung nodule. CT shows lung nodules smaller than 6 millimeters. So we see a lot on a CT of the chest. We like it. All right, CT imaging or PET help in determining metastasis to the liver, brain, and adrenal glands. And bronchoscopy can be helpful in assessing the location and extent of the carcinoma. So the prognosis is 12 to 14% over 5 years. Not very good, is it? The causes of smoking, carcinogenic substances in air, and occupational exposure. The treatment is surgery, chemo, external radiation, brachytherapy, or any combination, or all the above. Do whatever we can because your rates aren't good. Squamous cell carcinoma, this is what it looks like. The thing that I think is interesting is you can see the little fingers, the little hairs that are aggressively attacking and growing. And this is on a chest x-ray, what it looks like right there. Undifferentiated small cell, so all in here, small cell carcinoma. All right, Mets from other sites, more common than primary lung neoplasms. Most common sites are from the breast, the GI system, the female reproductive system, prostate, melanoma, and from the kidneys will go to the lungs. They get there through the blood, the lymphatic system, or direct lesion and local invasion, so it's eating its way up into the lungs. Bronchiogenic metastasis also, and direct implantation from biopsy or surgery. So there's seeding. So if we do a biopsy, we can actually leave little small traces of the cancer all throughout. This is not good. This looks like sarcoma, to be honest with you. So you see big fluffy cotton balls within the lungs as metastatic disease. When we look at the pathology summary, as you can see, with all of these, it's all chest x-ray, Most of them are additive except for the subtraction, which is COPD, and emphysema will be within that also. So chest CT is also very common. So in MRI, we typically do not do any imaging of the chest. We will do imaging of the heart, but that is a different chapter. All right, that is your lecture on the respiratory system.